Thanks, everyone. First of all, it's a real pleasure not only to be on the Scientific and Ethical Advisory Board, but also to be here. It doesn't really feel much like work, listening to everybody else's hard work, but I guess I've got a bit of payback now because I've got to talk to you all. It's a bit scary calling this a masterclass, speaking to a room of professionals so passionate and knowledgeable about exercise, but hopefully I can bring a slightly different aspect, thinking about my day job. So I work for Great Ormond Street at the moment. I'm head of psychological services there. And prior to that, I was at Oxford Children's Hospital working in paediatric hemonc and spent a lot of my time working with the multidisciplinary team on supporting children and young people and their families to really engage in behaviours that might be very difficult, might be tricky. So whether that's hospital, school, exercise, physio, any aspects of rehab, medication adherence, supporting children and young people to do things that they really would rather not be doing was a big part of my day job. So hopefully I can share some of my thoughts with you. And it was really interesting to sit back and hear about the challenges with recruitment and some of the factors playing into that. So it would be good to think about that as we go through. I think I've only got 10 minutes, so I'm going to be really quick. But I'm hoping to talk a little bit about the psychological aspects of behavioural change, particularly in relation to exercise, and consider the additional challenges that children with cancer and their families face when thinking about exercise, and hopefully discuss the implications for FORTEe and beyond. I'm primarily a clinician, so a lot of my interests are how does research get translated into the clinical world, how can we make most use of the amazing work that goes on, and hopefully share some thoughts on that at the end too. So why does psychology matter? Why are we part of the multidisciplinary team? And really, this link here, that we call it a hot cross bun on many of the models, it's a four-way diagram. But we know that one of the primary drivers for our behaviour is our thoughts. So it does not matter how many times people tell you to do something. If you don't want to do it, if your thoughts are telling you not to do it, you're not going to do it. So we heard about intrinsic motivation. Absolutely, extrinsic motivators work too, but your brain still has to say that's a good idea because I want to get that treat. So how we think about something affects how we act and how we feel. They're really key drivers underpinning everything that we do. And we know there's so much research out there in physical health looking at appraisal styles, our cognitive styles, and how that links to functional outcomes. We know that people do better functionally if they have a certain type of thinking style, a challenge-focused thinking style. We know that many of our families in paediatric oncology get shifted into a threat-focused thinking style because of the situation that they're in. And really that has an impact on then how we behave. We know that it's not just the in-the-moment stuff that impacts on our thinking. There's so much that goes on underpinning our in-the-moment thoughts, our historic belief systems, the family beliefs, the family behaviours that we've observed, financial and environmental factors. Heard a lot today about the challenges of trying to do your exercise programs with the kids to be interrupted by the staff that need to come in and do OBS, for example. How does that impact on your thought about how important this session is at the moment? So a huge amount of stuff that's impacting on the work that you're trying to achieve here. It's not an easy job at all. I was really interested in that discussion just now about why some centres might be operating differently, getting a higher exercise dose than others, and I'm sure there's a huge amount of stuff underpinning that process. So how does this relate to exercise? How does what I do relate to what you guys are trying to achieve? We know that exercise is a notoriously difficult area to change anyway. If you are lucky enough to be healthy and you think about what happens when somebody says to you, oh, come on, let's go out for a walk, and it's cold and you don't feel like it. How easy is it for any of us to do stuff we don't really want to do when we're not feeling up to it? And add into that the demands of a child and their family going through cancer treatment. It's incredibly difficult. So I'd just like to invite you to reflect for a moment, spend a lot of your time trying to get other people to do exercise, but let's just have a think. What thoughts do you have about exercise? Where have they come from? How does it feel and what do you think when you're not really feeling up to it and someone's trying to persuade you to do something that you don't really want to do? And what makes a difference? What gets you there? What changes your thought process? And what's different, what works for you is going to be very different to the person sitting next to you. And there's a good reason for that, because they have different belief systems, different past experiences, and so on. But getting this right on an individual level for our families is really key to achieving the outcomes that you're working towards. So just a little illustration here. We've got this obviously very generalized and very sort of black and white, but person A and person B, both of them have very different thoughts around the importance of exercise to them right now. But how might this impact on recruitment? Which one are you most likely to recruit for your study? Which one are you most likely to get to the higher exercise dose that you're looking for? Add into it the fact that we know having a cancer diagnosis disrupts pretty much every developmental process a child is going through. So it's not just beliefs and behaviours around exercise that gets impacted on by a cancer diagnosis, but attending and engaging in education, medication adherence, parenting, behaviours that children are allowed to get away with, screen time, pretty much disrupts every aspect of life. And your job on this study really is to overturn a lot of this stuff. And what a difficult job that is. So how can we think with people about the importance of exercise to help them engage in a different thought process, leading to different behaviours? We know from work with parents that at the forefront of their mind, when their child is diagnosed with cancer and is being treated for cancer, the first and most prominent thought is my child going to survive? Are they going to be okay? And even previously prioritised aspects of life and behaviour will get deprioritised all of a sudden. So even if you are that person A, you're that parent A, that suddenly becomes a lot less important. What I'd like to think about, and certainly in my clinical practice and the services that I'm lead for, is how do we get that message across right from the point of diagnosis, that maintaining as much normalcy in these everyday behaviours, be it exercise, be it nutrition, be it school, parenting styles, getting the consistency throughout is really going to be beneficial when it comes to end of treatment. And obviously we're all working towards curative treatment for children with cancer, and we want that return to post-treatment life to be as smooth as possible. So the messaging from diagnosis is really, really important. And I noticed somebody said about the doctors coming in right at the start being a really positive factor. And absolutely, however many staff we can get sharing those messages is really important. So a little bit more detail. I don't know if people have come across the health belief model before, but it's an old model, but it's a good model, and it really helps to understand why we might behave in the ways that we do, and what we can do to change some of the behaviours through understanding how the person feels about the aspects of the health belief model. So, for example, perceived seriousness. If you think, do you know what, exercise isn't going to matter, it's not going to make a difference, chemotherapy is the most important thing right now, the perceived severity of what could happen if you don't engage in exercise behaviours is going to be very low. If you have the doctor coming and saying, hey, this is really, really important here, suddenly you're improving that ratio. So thinking with each individual family, maybe the families that you're struggling to recruit, maybe the families that you're struggling to get that extra session of exercise in, having to think about what you know about them, what is in their health belief model, and what is within your control or within your team's control to try and change some of the narratives about that. Cues to action. So I know some of you struggle, you haven't got the equipment on the ward, you've got to go downstairs, you've got to get it, you haven't got a gym, you haven't got a climb-in wall. Those cues to action that children are seeing in other hospitals aren't present in your hospital. How can you change that? So thinking about which aspects of the health belief model relate to your setting, your patients, is going to be really important in that end goal of the likelihood of them engaging in the health promoting behaviour. This is another old but good model, the model of change, or the stages of change model. And I just want to briefly mention this. You might well be very familiar with this model, but if you're not, there's a very classic pattern that happens with interventions that we want to trial, and that is these interventions are really good if somebody's at the preparation and action stage. If you're at the pre-contemplation stage, you're not even thinking about making a change. As many parents, when their child is diagnosed with cancer, hardly anybody says, hey, What about exercise? What do we do when you've just received a diagnosis? You're at that pre-contemplation stage where you're not even thinking about it. Contemplation, you're thinking about it, but maybe you're not quite ready to make a change yet. You know in theory that more exercise is probably a good idea, but actually you're not ready to step into that preparation stage. Many of our interventions are really effective if you're at preparation and action, but many of the people that we've talked about today will be at that pre-contemplation and contemplation stage. What do you need to do to shift them to the later stages of the model to get your intervention in and being effective? So just thinking about how do we know which stage people are at, what are the clues, what clues do they tell you that they're at these early 2 stages, and how can you take a step back from what often happens is that we start to try and persuade people that this is a really good idea. So we know that the same strategies don't work at each stage, and combining your understanding of the beliefs around health and behaviour change and the stage that the family are at hopefully will lead to more successful outcomes in the behaviour change itself. So obviously in a 10-minute talk, we haven't got much time to talk about how you actually do that. There's some links at the end if anybody's interested in thinking more about that. But here's some ideas about questions that really come from a motivational interviewing perspective that will help people to think about the kind of things we want them to be thinking about to get them moving through that stage of change model. A really interesting one that, again, I've been part of lots of conversations. It's brilliant being here and being part of the conversations. What motivates you? What motivates your child? We know that for little kids, it's all about having fun. It's being in the moment, and it's the disruption that cancer treatment has to that in the moment, day-to-day fun, playing with your friends and so on. So instead of saying it's time to do your exercise, could we say, it's time to have some fun. It's time to do something fun. And those very simple shifts aligning with what motivates somebody in that moment are so important. So thinking again about parental motivators, we know that probably the biggest predictor of child behaviour is parental behaviour. So we really need parents on board with any change. The child motivators we've talked about. What information and support, so thinking back to that health belief model, if there's some misconceptions that, my child is too unwell, this might be damaging, so on, we might need to look at information and support seeking around that, and the environmental supports to get those cues for action right. Obviously, this is a research study. You've got ethics, you've got your protocols, you have to give out an information sheet. There's only so much you can do before you're allowed to sort of have these kinds of conversations. So I just wanted to acknowledge that that's not always easy within a research protocol. But what aspects of this are possible within the protocols that you have to follow? And how do we ensure that these studies are not just recruiting the people those people A that have the positive exercise cognitions in the first place, because we really do want to look at this right across the board. So there's a little bit more information here if you're interested. The other thing I just wanted to mention based on the discussion before we went for a break, what's really interesting for me as a clinician, and I get involved in a lot of this stuff, bringing the clinical perspective to research studies, is after this we want to know how do we implement it, what's going to work. And whoever is interested in, power analysis and stats is going to kill me for saying this. It's really helpful to know what happens. Why has one site got only 1 exercise dose per week? What are the conditions? Because I want to know when this comes back to my hospital, what do I need to be in place to get 3? What are those differences? If your stuff's off the ward, if you get interrupted, if you haven't got a gym, it's not just about what is the results, what's the effect on the child, but it's what's the conditions that are necessary to make this happen in the real world. So even though it might be rubbish for your stats, maybe some kind of checklist looking at all of the different parameters that we think and doing a stratification of what makes the difference to your dose would be a really useful clinical intervention. So I just wanted to throw that in at the end. I've probably gone a couple of minutes over, sorry, but thanks for listening.